Good afternoon, everyone. Thank you so much for coming for this lecture. We are very happy to welcome Dr. Has offered to take this lecture for us on approach to motor neuron disease. He is alumni from DON and he has also done his DM Neurology from CMC. He's working as associate professor in the Department of Neurology in CMC. So welcome. Thank you so much. Over to you, sir.
Thank you, Jennifer, for giving me the opportunity to talk in this neurology lecture series. I also like to thank our Department of Neurology and Prabhakar sir for giving me this opportunity. So today's topic, which I'll be discussing about, is something called as approach to motor neuron disease. I am restricting my approach to predominantly a clinical, and we will be trying to understand how would one consider a possibility of motor neuron disease and what are the important clinical features, discriminating features that one would like to consider in such diseases. So this is a disease which has been in vogue for a long time. This was described actually in 1824 by French physicians. The subsequent neuropathological studies and autopsies were done predominantly by this great French physician called as Charcot, who is considered the father of modern neurology. And he had subsequently followed up 13 patients, and then autopsy studies were done. Would recognize that motor neuron disease has two components to it. There is a lower motor neuron component, which is characterized by the anterior horn cell damage, and the spasticity component is being characterized by the sclerosis of the pyramidal tracts in the lateral column. So hence the name amyotrophy, meaning wasting, and lateral sclerosis indicating that the pyramidal tracts are involved. And from there, we have moved further in understanding the neuropathology, neurophysiology. We've been able to understand how the disease is able to progress. We've been able to make some groundbreaking theories and possibilities into why it is happening in certain genetic conditions. But unfortunately, it still remains an incurable disease. So before going into motor neuron disease, I think it's important to understand the anatomy of the pyramidal tract and the lower motor neuron. So the upper motor neuron comprises of the pyramidal tracts, which come from the motor cortex and right down to the bulb, as in the brainstem, and to the anterior horn cell for the spinal cord. And hence the pyramidal tracts have both cortico-bulbar fibers, which are going into the brainstem, and corticospinal tracts, which are coming to the spinal cord. And from there, from the spinal cord, you have ventral cell, where the ventral rootlets come out, and subsequently they join the spinal nerve, and the motor nerve part of the nerve goes to the myoneural junction, and subsequently the muscle, and innervates the muscle. So that is how the motor system is classified into. So the upper motor neuron comprises of the pyramidal tracts, which come from the cortex till the anterior horn cell, and from the anterior horn cell, including the anterior horn cell, is considered lower motor neuron. Now, motor neuron disease is a very wide spectrum of disorders, of which we commonly see in our clinical practice. It is the most common variety of motor neuron disease, something called as amyotrophic lateral sclerosis, which comprises 85% of most of the cases of motor neuron disease. However, it is important to understand that there are other variants of motor neuron disease, and we classify them based on whether they have an inherited etiology, that is, if they have positive family history, other siblings being involved, a family history positive, or if they are sporadic onset. And we divide them further, whether are they element dominant, or are they upper motor neuron dominant. And based on that phenotype, we classify them into different kinds. So and predominantly element dominant are called as the progressive muscular atrophy variant. The one which is predominantly the upper motor neuron variant is predominantly called as a primary lateral sclerosis variant, and the one which is most commonly seen in the classical cases that one sees in the OPD and in clinical practice is something called as amyotrophic lateral sclerosis, where there is mixture of upper motor neuron and lower motor neuron. Among the amyotrophic lateral sclerosis, we have other subvariants, which I'll be coming subsequently in the lecture. Now, in the inherited forms, the upper motor neuron dominant forms comes the hereditary spastic paraparesis, And in the lower motor dominant form, you have the spinomuscular atrophies and the spinobulbomuscular atrophies, which come. So, in the clinical approach to such disorders, I think Prabhakar sir was given an example of how one should clinically approach these disorders, how to make an algorithmic or a syndromic diagnosis and then subsequently anatomically localize them. So there are certain important, so when to make the syndromic diagnosis, one should get the key details in the history. And these are the minimum requirements that one requires to make this syndromic diagnosis. So as in any disorder, one always starts with what is the extent of the involvement? Is it something which is involving the motor, sensory, autonomic, or is it only motor? And if it is motor, which is meaning weakness, what kind of weakness is it? Is it something which is suggestive of an upper motor neuron kind of weakness, or a lower motor neuron kind of weakness, or is it both? Is the presentation and the progression of the weakness symmetric or asymmetric? Is there a fluctuation in the weakness over time, days, weeks? What is the tempo of progression of the disorder? Is it something which is rapidly progressing, slowly progressing, or now plateaued and not at all progressing? Is there historically or clinically any evidence to suggest that there is sensory involvement? And what is the time frame of the disorder that we are looking at? Is it in decades? Is it in months? Is it in years? Or is it in a few hours to minutes? How has it presented to us? That is these are the key questions that one needs to answer in getting probable syndromic diagnosis and coming to anatomical localization, decent anatomical localization. Now, so when I mean by we like to understand that we would like to understand what kind of weakness is it. Is it an upper motor neuron kind of weakness, meaning that in the history the presentation will be like tightness. If it's in the lower limbs, it'll be tightness. If they might say that they are unable to walk as fast as before. They might not be able to catch up with their peers. They might not be able to run and enter into a bus. They might be tripping and falling because of the foot drop that they're having, because of the pattern of weakness that they have. They will have, they might even notice clonus also historically, and there will be apparent lack of wasting. They may not notice any wasting or fasciculation in the history. Historically, they might not notice that there is any thinning of the limbs. While in a lower motor neuron kind of presentation, they notice that there is thinning of the limbs over time. There is fasciculations, and these are the important, apart from the weakness, which is common in both. So the weakness does not tell us whether the pattern is upper motor neuron or lower motor neuron. Apart from the weakness, what is it? What are the other features? Is what tells us is it upper or lower motor neuron? And this is very important because the disease starts in a particular way, and then it progresses in a particular way. So what is important rating all throughout my talk is this is a progressive disorder, and it is not something that's static, and so progression is an important hallmark in this condition. Now, apart from the motor weakness that one defines with the syndrome, some of them can also have some cognitive impairment also associated with it, and predominantly it affects the frontal lobes and hence and occasionally the frontotemporal lobes. So predominantly the manifestation that we might be getting in the history, apart from these upper and lower motor neurons, limb weakness, would be any history of behavioral abnormalities, difficulty in carrying out the day-to-day activities, or sometimes even language dysfunction, which is an added history but may elicit apart from this. Other important thing which I forgot to mention apart from limb weakness is bulbar weakness. Now, this is a syndrome which not only involves, just like I mentioned, in the pyramidal tract, and it has a cortico-bulbar involvement and a cortico-spinal involvement. So the upper motor neuron and lower motor neuron, which I just mentioned, was for the cortico-spinal. With regards to the cortico-bulbar, it would be that they have significant speech difficulties. They have difficulty in articulating certain words. They find that their speech is becoming progressively slurred. Then they gradually develop difficulty in swallowing. So for an upper motor neuron kind of a disorder, especially with this, that the articulation is more involved than the swallowing. Generally, that is what we see. So speech is more involved than swallowing. That is something which is evident early on. They find certain words, certain syllables, especially lingual syllables, are predominantly involved for them. And gradually they find that they have, if it is an upper motor neuron kind of bulbar weakness, then choking is the history that they generally give. While if it is a lower motor neuron kind of corticobulbar, I mean, like a bulbar involvement, then it would be regurgitation, which could be the presentation. So these are the important history that we would like to elicit. Are we getting choking more? Are we getting regurgitation more? What is is there a dysphonia or is there a hoarseness in the voice that has happened over time? So these are all adjacent regions anatomically. So hoarseness of voice, speech being progressively becoming unclear. It's important to understand that this is an articulation problem. This is not a language problem in the bulbar involvement. So they are able to understand everything that you're saying. They can, to such an extent that they can become absolutely anarthric or mute, where they will not be able to utter a single word, but still be able to communicate by writing. And they'll be able to read also, indicating that this is not a language problem, but this is an articulation problem where the tongue and the jaw muscles and the facial muscles are becoming progressively involved, and hence they are not able to say anything. And who do they affect? So most of our population studies are coming from the West, Caucasians. So generally considered that it affects men more than the women. Generally, the ratio is around 1.6:1. And generally in the West, they consider the age of onset is above 50 years, and 50 to 70, 50 to 65 is the average age group of involvement. It can generally very elderly, we don't find it very commonly. So in India, we find that ALS actually affects a decade earlier here. So that is our experience in seeing such patients. But however, any patient who comes less than, younger than that is considered, we will be evaluating him and investigating him before saying that he has something called ALS. So again, as I mentioned before, and again, I would like to reiterate, this is a progressive disorder. So one should not consider, or one should, in your history taking, that is something which it is important. Apart from the history where we take where is the weakness and how did the weakness involve other regions, it's important that we always get the idea, the tempo of the progression should be progressive, and that at no point in time do we understand that the disease has become plateaued. So inexorable progression is the hallmark of the disease. And without a progression, the patient has motor neuron disease. So there are three common patterns that we see, of which the first two are the most common patterns that one sees in clinical practice. So the most common presentation that one sees is the limb weakness presentation, or the limb onset phenotype, as we call it, where they come with asymmetry, and it is painless, and they gradually develop distal weakness of the limbs, and it is historically and clinically without any sensory loss. So this pattern is the most common pattern that one sees. The limb weakness could be in the hand or could be in the leg, and it is generally asymmetric, and it is distal, and it is painless. So these are important points which I'd like to highlight. And historically also, we never get any sensory loss. The second common presentation that one sees is focal midline weakness. For example, bulbar or neck drop, progressively involving the neck muscles, especially the neck extensors, and they progressively coming with a neck drop. Or some of you might have seen such patients coming with a collar to your OPD, the collar preventing them from, prevents a forward drop. And it's quite often that we mistake them for having a cervical spondylotic problem, and referring them. It's actually, one never gets such problems with cervical spondylotic diseases. So it is a neck weakness that one is seeing there. And the least common, or this pattern, if you see, that one never considers motor neuron disease as the first differential, is if you have a symmetrical weakness. So if you have a symmetrical weakness, both upper limbs and both lower limbs involved, or both upper limbs involved, so these are not common patterns that one sees. So I'd like you to remember that two important things are, it's a progressive disorder, and the most common presentation is an asymmetric distal limb weakness presentation, or a midline presentation like neck drop or progressive bulbar involvement is the other most common presentation that we see in clinical practice. So these are some photographs which I'd like to show of such patients. So if I can take your attention to compare between the right and the left hand, it is quite evident that we can see there is significant wasting of the thenar eminence of the left hand as compared to the right hand. And you can also see that there is clawing in the left hand as compared to the right hand. And I'm not sure if you're able to see it in the photos, but there is also significant wasting of his first dorsal interossei and the other interossei of the dorsal aspect of the hand as compared to the right hand. So this wasting, at least on the palmar aspect, if you're able to appreciate, I would like to highlight that this asymmetry is what I'd like to highlight, is what I mentioned as the most common pattern. Or this is another important, so again the same photograph in from a different patient, where this wasting that one sees even in the hand, there is some the way the topography of the wasting in the hand is also little different. It predominantly there is a predilection to affect the lateral aspect of the hand, or the thenar eminence, and the in the dorsal aspect of the hand, the first dorsal interosseae are predominantly more affected. If you notice carefully, the hypothenar eminence or the abductor digiti minimi is relatively spared as compared to the thenar involvement and the first dorsal interosseae involvement. So such a relative asymmetry even in the hand that is involved is what one sometimes calls in clinical practice a split hand. So where they have a split hand involvement, where the thenar, the lateral aspect of the hand appears to be more involved than the medial aspect of the hand. So among the phenotypes of amyotrophic lateral sclerosis, these are the different phenotypes that present to us. So among these, I'd like to draw your attention predominantly to the first two ones, because these are the ones which commonly present to us, or the two common patterns which I described before. So the presentation could either be the coloring indicates orange is low motor neuron. So the presentation could be at onset in upper or lower motor neuron. That depends on the history. So it could be in the leg, it started as stiffness, tightness, inability to walk faster, cramps, and then that is in the right lower limb, and then going on to the right upper limb, involving as wasting, fasciculations, and weakness. So generally the involvement is segmental. From the right upper limb, it goes to the right lower limb, and then henceforth. So we have this rostrocaudal and segmental involvement that we normally see in the spinal onset variant of ALS. The second common variant, as I previously told, was the bulbar, progressive speech difficulties, swallowing difficulties, emotional incontinence in the form of pseudobulbar effect, like how we call it, where with trivial things they tend to laugh uncontrollably or cry inconsolably. Such presentations where they have a pseudobulbar effect is quite common in the bulbar onset variants. And then the lesser ones, which are common, lesser variants, are the progressive muscular atrophy. These are the symmetrical variants which we were discussing, where they have predominantly LMN. So it remains as a lower motor neuron kind of a dysfunction for a very long time. And or if you look at the next one is primary lateral sclerosis, again symmetric and upper motor neuron kind of involvement. So the dominant feature would be spasticity and not wasting and not fasciculation. Not that will be the dominant clinical finding. And if you see, there are certain small islands in the thing. These are small islands of element that one may get clinically, or maybe on electrophysiology we might get some small islands of element. But the dominant clinical picture will be of a dominant upper motor neuron dysfunction. There are other presentations like this, which is called as a pseudo polyneurotic presentation, where it actually mimics a peripheral neuropathy like presentation as bilateral foot drop and all. So these kind of ones are relatively very difficult, because we must understand that as one sees, when they come to us initially, it might be just the disease which is evolving, might be starting in one limb, because generally there is some asymmetry to it. So it is sometimes a older gentleman coming with a foot drop on one side, and some back pain is often misconstrued and probably labeled as a L5 radiculopathy, and sometimes we often see them going ahead and getting a surgery done, saying that there's a disc which is involved causing that, and then subsequent progression indicating that no, it was not, when it was actually the ALS which is actually presenting as the foot drop, and it was not the radiculopathy. We have multiple instances of such instances happening, even with this variant or with the flail leg variant, where it remains in one leg for a long period of time. So you must understand that even this is when the disease completely evolves, and it's relatively easy to understand, and it is easy to diagnose. But always the problem is in diagnosing it in the onset, and so one must be aware that the patterns is what help you, and the progression, and not that you can't look at it from one point in time and say that this is ALS, and that sometimes it is not very clear at the onset. This is the problem that one always faces when we see these patients initially, and then when we subsequently follow them up. Sometimes subsequent follow-up is required to understand what is the pattern of progression in these patients. And these are very, very rare variants, like these hemiplegic variants, where they remain upper motor neuron and almost look like a progressive hemiparesis, where they only a progressive hemiparesis that they have, and all investigations and evaluation being negative. And these are very rare variants that one sees very rarely in clinical practice. So a few more words on these phenotypes. So the bulbar presentation of the motor neuron disease, there are two types. One is a type which remains bulbar for a very long time. Another variant is a bulbar onset, which starts in the bulbar and then progressively involves the other myotomes in the upper limbs and the lower limbs. Now, the ones which start in the bulbar and then progressively involve the upper and lower limbs have a poorer prognosis. They tend to progress faster and shorter lifespan, and these are the ones which we say have poor prognosis from the onset. So the ones which remain isolated bulbar for a longer period of time tend to have a better prognosis because they are generally upper motor neuron type. So the ones which progress, if they develop the lower motor neuron dysfunction, then that means the chance of aspiration is more. So once you have more of LMN kind of bulbar weakness, aspiration chance are more, chance of pneumonia is more, and hence the chance of death is more. So the ones which progress is the most common ones, while the ones which remain are little lesser. They remain as isolated bulbar. So the spinal variants I've already mentioned. It's important to understand that the bulbar involvement is always symmetrical, and that you don't see a wasting of one side of the tongue alone, or wasting of one side of the face alone. That is not common. So it is always important that this is symmetrical involvement in the bulbar, unlike the limb, which is asymmetrical. The bulbar involvement is always generally symmetrical. So if you get a patient who has a tongue wasting which is asymmetrical, please, we will not consider ALS as the first differential. We must consider other possibilities like a hypoglossal nerve or something else as the possibility, and not ALS in the first differential. So spinal variant is the one we have already discussed. So sometimes it's important to understand that it's how they progress gives us more onset. And these are instances where sometimes electrophysiology helps us, which I'll be coming to later. So then we have the patients who have either the presentation as onset as bulbar or spinal weakness, that is limb weakness or bulbar weakness, who also develop frontotemporal dementia changes. They have behavioral changes, executive dysfunction, or sometimes language dysfunction. And then the other common ones which I previously told was the phenotype which remains bulbar. Now this phenotype is more commonly seen in middle-aged women. Like I told you before, ALS is more common in men than women, but this phenotype is more predominantly seen in middle-aged women more. They remain as upper motor neuron dysfunction more, and these ones which do not progress to the other limbs may have a better prognosis. They tend, because they are upper motor neuron more, they don't and there is no further progression to the other limbs. They tend to have a little better prognosis as compared to the other ones which progress. And very restricted forms which are like I told you, which remain only LMN, these are rarer variants, or only the progressive muscular atrophy. They're the only LMN variants and the only upper motor neuron variants. We do not call them because sometimes it's a disease in evolution. It might start as a lower motor neuron disorder, and as we clinically examine them multiple times over months, we find that they are gradually showing upper motor neuron signs in other areas of the limbs which were not present in the initial OPD visit or maybe admission. And so examination is sometimes important in understanding these cases, and that one should not close these cases prematurely and say that this is probably. It's important to follow them up longitudinally. And the very rare variants which one sees very occasionally are the cachexia variant, where they come with just weight loss, and the isolated diaphragmatic variant where they start as a diaphragmatic involvement. And this is important for the because it doesn't come to the neurologist, because it is diaphragm which is primarily getting involved. They generally come with orthopnea, and so when patients develop orthopnea, they do not come to a neurologist. They probably go to, because the most common possibilities are probably see a congestive cardiac failure and lung pathologies, and they primarily go to a cardiologist or a pulmonologist for further evaluation. And because there is significant orthopnea, they might even land up in the ICU because of respiratory failure, maybe requiring intubation and all that. So maybe our first consult for these patients might be coming from the ICU kind of setting, and these are very rare variants. So why is it important to classify them? Is because each of them have a different prognosis. Like I said, the bulbar onset ones, which starts in the bulb in the tongue and then progresses to other limbs, as you can see here, because swallowing is nutrition gets involved, malnutrition sets in, there is weight loss. Then as it involves the other muscles, the diaphragm, they start developing orthopnea. Because of recurrent microaspiration, they develop aspiration pneumonia. And so if you have a bulbar onset dysfunction, we are very early in the disease, we tend to tell them about nutrition helps them in prolonging their survival. And so peg feeding is discussed with the relatives and the family at a very early stage. Bulbar dysfunction is a common problem. And so phenotypically putting them, even though the disease doesn't have much treatment options, phenotypically differentiating them into these variants helps us in treating them differently and prognosticating them differently. Even though we say that sensory complaints are not a major manifestation of ALS, there are some symptoms which I think is important that we understand. Most of these patients, when we follow them up or ask them before the onset of disease what they had, cramps is something which is something very commonly they have before the onset of disease. In fact, nocturnal leg cramps are something which they have a lot. And pain is also an important problem that they all have, and generalized fatigue. So these are important things that they also have. And when you follow up these patients, these might be the most common symptoms that you might be treating them for. And as previously discussed, because of the bulbar involvement, they have significant malnutrition, weight loss, which needs to be addressed. Considering might need a peg tube because to address the malnutrition. And because of the significant bulbar and the pharyngeal weakness, they have significant siluria, and that could be a very socially embarrassing symptom, and it might need further treatment for that also. So I have discussed what all can be involved. So we understand it's a pure motor system disorder. Spares the sensory nerves. It spares the bowel and bladder. It spares the ocular involvement. But what is involved is the corticobulbar and corticospinal, and you can have dementia as a presentation. So the extraocular movements and the bowel and bladder are generally spared till very late into the disease. And that is why in patients with end-stage ALS in the Western countries, they use eye tracking software as a method of communication. In patients who have great difficulty in communicating, that they're so weak that they can't use their hands to write, eye tracking softwares are used as a method of communication. Now, the reason why these specific, that is the 346 renal nerves and the on-off nucleus in the S234 is relatively spared, we have only multiple hypotheses. They understand that that the innervation of the motor neuron to the myoneural junction is different, especially in the oculomotor muscles. The type of myosin heavy chain muscles and the intrinsic vulnerability of these nuclei are different as compared to the spinal nuclei is what has been considered. So these are the various theories which has been propounded to why these areas are relatively spared, but we have these are all at the we still are, these are based on neuropathological studies. So so if a patient has a particular presentation like an asymmetric limb weakness or a progressive bulbar weakness, there are certain signs, if you are able to elicit, will be highly suggestive that you are dealing with a ALS like presentation. So if fasciculations are very dominant in presentation with weakness and other symptoms and signs which I mentioned, and it's important that one might have to undress these patients because it's predominantly present on the shoulders. So you might have to undress them, you might have to ask them to be you might have to ask them to hyperventilate, and you might need to see, then only you'll be able to see these fasciculations which are especially common over the shoulders. And as previously mentioned, wasting is always symmetrical in the bulbar regions. So asymmetric wasting one should not consider ALS. And significant pseudobulbar effect presentation. So if you have a significant bulbar weakness, so that is wasting, fasciculation, the tongue, swallowing difficulty, regurgitation, and concomitantly in the same level, we are getting pseudobulbar effect, where emotional and there is emotional incontrollable crying or laughter. So that indicates there's an upper motor neuron dysfunction above it. So in the same region, we are getting both upper and lower motor neuron. If these kind of features are there, that is suggestive of a probable ALS-like presentation. A head drop, if that is the onset of the disease, that is an important symptom and sign for motor neuron disease. But it's important to know that it's common even in patients with myopathies, especially inflammatory myopathies, and in patients with myasthenia also. So neck drop is an isolated feature. One should not consider ALS, but in the context of progressive limb weakness, asymmetry, absence of sensory loss, brisk UMN signs, and head drop is an important sign that one should elicit. And additional, apart from the limb weakness, if there is additional cognitive impairment or behavioral impairment, those are also additional points that in a frontotemporal kind of pattern. These are also additional points which help us in saying that this could be, or we are probably dealing with an ALS-like syndrome. So when should you consider, reconsider your diagnosis? So that is also important. So I have told you about the most common presentations, and I've talked to you about what are the signs that will be highly suggestive. Now it's always important to understand which are the red flags, as how our teachers tell us, which are the red flags which makes us uh, diagnosis of a motor system disease. So that is, if you have sensory involvement, especially in the history also, it's also taken as important. Like if the patient says at the onset of the weakness, he had paresthesia and tingling and numbness. And those are all important features that even if you may not be able to elicit it objectively, history is also given equal importance to in sensory exam, because that is not a common symptom that we get in motor system disorders. If there is additional extrapyramidal involvement like bradykinesia, rigidity, and all, these are also not common involvement with this thing. It is important to understand that sometimes you, because of the wasting and because of the fasciculations in the hands, when the hands are kept outstretched, you might find these asymmetric hand tremors, and these are actually tremorlessness because of the fasciculations in the hands and what we call as polyminy myoclonus. And this is actually an element problem. The fasciculations are driving the movement, and it is asymmetric and arrhythmic, and it is actually not a tremor, but it may be mistaken for a tremor in certain individuals. So if you have that, that is more favoring ALS. But if you have tremors and rigidity and bradykinesia, and so we are considering non-ALS like presentations. Significant autonomic involvement, like I told you, the bowel, bladder are relatively spared. Postal hypotension, any of these symptoms, if they are there, then that is not consistent with the diagnosis of motor system disease. And very rapid progression, patient becoming weak over a week. I mean, patients becoming completely quadriplegic over a week, over days, over minutes. Those are not presentation which are consistent with the motor system disease, or in progression over many years where he had the weakness that has remained static, or improvement in the history, or relapsing remitting kind of presentations. Definitely one should, if that is the tempo of the illness, one should always reconsider the diagnosis of motor system disease. Fluctuations, and especially common, especially in the progressive bulbar kind of presentations, the ones where they come with dysphagia more than dysarthria, significant nasal regurgitation, significant LMN kind of bulbar symptoms. Sometimes ocular symptoms might be missed in the first OPD visit. And so if there is significant fluctuation, they say that there is some worsening during the evenings, the mild limb weakness, which are better in the mornings. Such fluctuations, we must always consider that this could be involving the neuromuscular junction. And certain presentations where they remain upper motor neuron or lower motor neuron presentations for a very long period of time. They are not, and like I told you, the normal kind of ALS, it might start as a foot drop or as a hand weakness, but gradually they develop other upper motor neuron signs over time. A disease which does not manifest such symptoms, that is a possible red flag. In the presence of a systemic disease, it is very difficult to make a possible diagnosis of motor system disorder. Headache or pain as a dominant symptom. So if a patient develops acute onset pain in the shoulder and the neck, and then develops a weakness, one must consider that the possibility is more of a radiculopathy or a wasting rather than ALS as the manifestation. And if there is encephalopathy, so those are the presentations, and one should not consider ALS, but this is a disorder that, because we don't find encephalopathy as a common presentation in motor system disease. Now, there are certain important mimics. So when we anatomically, when we syndromically put it, the localization for these presentations, it will probably be like progressive right upper limb or right upper extremity weakness over a period of 6 months with wasting, fasciculation, then progressive right lower limb weakness with tightness, tripping and fall, and with examination showing both upper and lower motor neuron. That is the most common finding and examination history that you get in the classical ones. Now, it is important to understand that we will hence be putting them into these three possible categories. So lower motor neuron and upper motor findings, purely a bulbar predominant involvement, lower motor predominant involvement, and upper motor neuron involvement, which is, I forgot to add that. So if you have significant mixed upper and lower motor involvement, it is always important to look for treatable disorders. So in an elderly person who comes with weakness and wasting of the hand and progressive tightness in the legs, maybe sometimes they can have some occasional urinary urgency. The most common thing that we must consider in this setting is a cervical spondylotic myelopathy. Similar presentation in a young person, a 20 to 30-year-old gentleman who's coming with similar presentation where they have wasting in the upper limbs, human signs of lower limbs. The sensory dissociation may not be elicited initially, or we may not be able to get that in the first sitting. One must always consider there's a CV junction as a presentation of, and that the syrinx or the intrinsic cord is getting involved, and that is the reason why they have the wasting in the upper limbs. And always endocrine disorders like thyrotoxicosis, where the hyperreflexia, which might be the only thing for upper motor neuron dysfunction, where the hyperreflexia is given undue importance, and there is weight loss and other things, and the tremors are of the thyrotoxicosis is considered as polymyalgia myoclonus. We've had such instances in neuromuscular OPD where these patients have come with when the weight loss was considered as part of a cachexia in motor system disease, and very rapid progression was the reason why we evaluated them, and they find it was thyrotoxicosis. So these are very reversible causes. Neurofibromatosis is also something very common in India, where multiple neurofibromatosis can involve multiple roots and nerves, and it can present with significant wasting, fasciculation. So neurofibromatosis always remains. So systemic examination looking for neurocutaneous markers remain an important thing, especially in young people who come with ALS-like presentations. The bulbar mimics, the most important mimic that we will always consider will be myasthenia gravis, especially the muscle-specific kinase kind of antibody presentation, which happens in the same age group like ALS, 40 to 50-year-old, predominantly the women, and they might not have ocular as the most common presentation. The most common involvement would be just the bulbar and the neck drop. And so it might be just and they might even have fasciculation of the tongue, wasting, and it exactly mimic a motor neuron disease. We have multiple such case examples like that, which has been initially labeled as motor neuron disease and subsequently being called as myasthenia gravis, getting intubated, and subsequently we were able to treat them and wean them off the ventilator, and them finally having a good recovery. And the other important thing is skull-based disease, meningeal disease. So meningeal disease is multiple cranial nerve palsies, lower cranial nerve palsy, especially in the skull base, can also mimic bulbar, especially when you have 9, 10, 11 involvement, 12 involvement. It can look very similar to bulbar onset ALS, but the important thing will be that headache will be a very common symptom in them, and that is not a common symptom that one expects for encephalopathy because of the meningitis and all. These are important things that one should be able to differentiate from ALS. The lower motor neuron mimics the most common thing that we see. Depends on the age. So between the ages, adolescent boy who comes with wasting and fasciculation, which remained in the hand, started in one hand and then went to the other hand. It's very common that Hirayama is the most, or very segmental kind of anterior horn cell involvement restricted to the upper limbs is the most common presentation. And sometimes we get polyradiculopathy, again meningeal disease, or multiple roots getting involved, where they come with progressive flaccid quadriparesis, and it is the multiple roots which are getting involved, or arachnoiditis, which is causing the weakness. In India, the other common problem is post-polio syndrome, where so here the prior history of poliomyelitis in childhood, maybe there might be a limb-leg discrepancy, there might be some contractures in that leg or prior significant history, and then many years or many decades later they develop progressive element weakness in other limbs with significant pain and fatigue. These are common symptoms. So having a past history of polio is important for patients with such symptoms. Where occasionally we see some toxic neuropathies, porphyria and all, or lead, which can mimic, where they come with wrist drop and they can have pure element kind of presentation where the nerve is getting involved and they may mimic like ALS. So again, it's an element dominant symptom. They have no upper motor neuron signs. Like I mentioned, neurofibromatosis, it can present as both element and upper motor neuron disorders. Occasionally, we have seen some peripheral nerve hyperexcitable disorders like neuromyotonia, where the neuromyotonia, the myokymia or the flicking, twitching movements of the muscle was interpreted as fasciculation by the treating team, and hence was considered to have ALS, while the common presentation for them is cramps, pain, a autonomic dysfunction where they start sweating a lot and all. So those things were not given much importance. The twitching, and that was misconstrued as fasciculation and hence being treated as motor neuron disease. And you have this asymmetric pattern of lower motor neuron weakness. Inclusion body myositis is a very important mimic, especially in neurology OPDs, where it is sometimes difficult to differentiate between the two. The selectivity in the muscle involvement, muscle disorders generally have some selectivity. Some muscles are less involved and some muscles are more involved, and the presentation and the progression and electrophysiology helps us in differentiating. And rare disorders like multifocal neuropathy, conduction block, where they come with progressive hand involvement, weakness. It's important to understand that in ALS, that involvement is in the anterior horns and in the pyramidal tract, and the weakness is a myotomal pattern of presentation. They are weaknesses in a segmental distribution along roots, while in nerve involvement, it is along the nerves. So a nerve it is important sometimes to find the difference between nerve pattern of weakness versus the myotomal or segmental pattern of weakness. So I like to reiterate this point multiple times. ALS remains a clinical diagnosis. We have no we have no electrophysiological test or no biochemical test or serological test that helps us in telling that this patient has ALS definitively. So ALS remains a clinical diagnosis for all patients here. And so what neurophysiology helps is that it helps us in patients who onset is very focal, and we'd like to know whether there's some subclinical involvement in other regions. That is where neurophysiology, electrophysiology helps us. A patient who has frank fasciculation, frank involvement of all four limbs, and clinically their sensory system is not involved and it fits into the pattern of weakness. EMG and NCV does not add much to the clinical diagnosis. While in patients who come, like I mentioned, a foot drop presentation where only there is foot drop and subsequent involvement in the EMG, finding out there are certain subtle involvement in other regions also. So the whole point of doing nerve conduction studies, EMGs, imaging is always to rule out treatable disorders, and if this will always be negative in motor neuron disease. So I will be just very briefly touching upon the EMG because my talk I would like to restrict to the clinical approach. So when we are looking at in the EMG lab, we are primarily, this is a disorder of the motor anterior horn cell, and it involves a motor unit. So a motor unit is one motor neuron which is coming from the anterior horn cell and supplying multiple muscle fibers. So if you look at the right side of the cartoon, you'll find that there is one anterior horn cell, there is one motor nerve coming, and it is supplying multiple muscle fibers. So this is what is called as one motor unit. So there are such millions of motor units which are present in each and every nerve, which is supplying multiple muscles. So what happens in patients with ALS is that there is a progressive degeneration of the anterior horn cells. Some of them are involved and some of them are spared, and the adjacent anterior horn cells will take up the other, when one gets degenerated, the other muscle fiber fibers innervation is taken care by the adjacent motor units, and therefore the motor units become larger. This cartoon, I'd like you to concentrate on this cartoon here. So this is one motor unit where there's an anterior horn cell as a motor nerve and supplying multiple muscle fibers. In anterior horn cell disease, what happens is these motor units degenerate. So additional motor units are supplying and innervating these muscle fibers and re-innervating them. So there is a denervation that is happening and a re-innervation that's happening from the adjacent motor units. And what happens is this is not a sustainable thing. At some point in time, the motor units just finally dies and there's hardly any more motor units to anterior horn cell to further re-innervate. And that is when the weakness develops and the atrophy develops and the weakness develops. So when a motor unit gets acutely involved, you get some EMG findings, and when it's chronically being involved, you get some EMG findings, which are called as fasciculations. So I'm not going to spend too much time on this, but it's important just to understand that there is a progressive loss of motor units in this disorder, and because of this, there is as much as if the reinnervation is able to keep pace with the denervation, weakness does not worsen. But once that it is not able to keep pace with the denervation, weakness starts developing. So the whole point of doing a nerve conduction study is, again, like I told you, to exclude other mimics. So maybe you're not able to elicit the sensory finding in the OPD, but when you're doing a nerve conduction study, maybe subclinical findings would be we might be able to elicit and say this is not likely to be a motor. And it depends on where the disease has started. Like I said, if it's an onset is in the bulbar, for example, in the progressive speech, and there's hardly any involvement in the upper limb and lower limb, a routine nerve conduct study may be normal because we are not doing nerve conduct studies for the tongue and all. So, and it's important that when you have diffuse involvement, all limbs are involved, the EMG just tells you that the involvement is in these regions, which you already know. So it does not tell you that this involvement is not because of this, it's not because of other localization which can also present like this. So the nerve conduction study and the subsequent EMG does not tell you that it has to be here. It just gives you that what is the extent of involvement, and that these kind of presentations can be present in multiple other possibilities also. So EMG, what it tells us is what is the amount of element burden in the disease. It does not comment much on the upper motor neuron burden, predominantly comments on the lower motor neuron burden. So we might so in the initial criteria of ALS, we needed certain these many number of myotomes we involved to call it as a definitive ALS initially in the initial criteria. So we used to do serial EMG. Sometimes the initial ones maybe only be restricted to one region, and maybe after 6 months or 3 months, when you see the patient again and when you repeat it, you might find that there is progression to other involvement. So that progression can be clinically and electrophysiologically revealed and as you follow up these patients. So we always tend to when we are doing needle EMG for these to needle the upper limbs, the lower limbs, the trunk, the paraspinal, and the tongue, the craniobulbar myotomes. So these are the myotomes that we examine with the needle. So very brief, looking at the criteria. So the initial criteria for motor neuron disease was initially proposed in 1990 in a place called LS Corel in Spain. So if you look at it, it's actually clinically diagnostic, clinically definite, clinically probable, and clinically possible, because there was no lab additional support here. And so if your patient had upper and lower motor neuron signs in 3 myotomes, you can clinically say the patient has ALS. You don't need anything else to say that the patient had ALS. So as from the 1990 criteria in 2006, what we understood was if you go by this criteria, you have to actually wait for the patient to progress through all these. Then only we are able to probably say that the patient has clinically definitive ALS. So for experienced clinics, so the problem was that it had a very good specificity in ruling out mimics, but the sensitivity was poor. So the problem with these criteria was that you needed a lot of time. So for an experienced clinician who's seeing these patients in OPD, you know from the first first OPD visit or the first admission visit itself that you are probably dealing with a ALS like disorder. And but because the criteria required you to have these many myotomes being involved, he did not fulfill the criteria for clinically definite ALS, and hence by the time they were enrolled in trials for too late, and it hardly showed any improvement. So hence people were asking for newer criteria to be involved so that they could be enrolled earlier into the disease, but at the cost of not including the mimics, which is treatable. And it's also important to know that the sensitivity is only 57% for them. So the whole primary point was that we should not involve a non-ALS patient and call it ALS. That was the whole understanding for the diagnostic criteria. So that's the new update which I like to tell for the exam going PGs was that there's a new criteria for the ALS, and that is the Gold Coast criteria. This has come recently in 2020, where they have tried to simplify it. So instead of saying definite, probable, and possible, they have made it into yes or no. So if you have a progressive motor impairment and you have presence of upper and lower motor neuron dysfunction in one body region or element in 2 body regions, and you've done the relevant investigations like imaging, electrophysiology, and you've recently excluded other mimics, then that was enough to make a diagnosis of ALS. So multiple subsequent trials have looked at the specificity and sensitivity, and they've compared it to the pre-existing ones, and they have found that it had a almost near equal 97% sensitivity and specificity. Much better sensitivity and specificity were present, but then these were at expert hands in neuromuscular clinics, and there can be bound to make mistakes when you have what you have tried to do is they have tried to get more patients earlier into the arm rather than waiting them so they progress much more. So I thought I'll end with some few clinical scenarios so that it's something that you will remember. So the classical presentation of a limb onset phenotype would be this, where an old middle-aged gentleman was coming with stiffness in the leg, difficulty in walking, significant muscle cramps at night, nearly for a year, and then subsequently noting twitching in the muscles, and then progressively involving the hand. This segmental rostrocaudal kind of involvement is what we generally see. And examination showing the pyramidal kind of involvement in the lower limb and element involvement in the upper limb, normal kind of sensory examination, normal cognition, and examination showing upper motor neuron and lower motor neuron dysfunction, no bladder, no bowel. So this asymmetric distal weakness without sensory loss, painless, without cognitive impairment, the localization being to the anterior horn cell and to the pyramidal tracts. And considering the phenotype, the most likely possibility was motor neuron disease. The important thing is because the bulbar was not involved at this point in time, he is just involved 2 myotomes. So it's important to rule out other mimics on spondylotic myelopathies and all are still possible in these kind of scenarios. And so imaging and electrophysiology is important in these conditions. And the bulbar onset phenotype is this 54-year-old lady who has come with progressive difficulty in speech, and then subsequently having developing dysphagia, history of pseudobulbar, features of both spastic and flaccid kind of speech, and examination, tongue showing wasting, presence of palmomental and sucking and rooting reflexes, in normal kind of power in the upper limb, and the EMG showing a disease is restricted. So this is a progressive bulbar kind of a presentation, where at this point in time, for 4 months, she has remained restricted to bulbar. She will need further evaluation, further serial examination follow-up. At this point in time, one should consider, we should look at the respiratory involvement here. We should look at the single breath count here. Look at the neck flexor. How is the neck flexion? Must maybe do an early morning ABG and see if there any early type 2 failure. Counsel them on the requirement of non-invasive BiPAP at some point in time, peg feeding at some point in time. So these are the kind of discussion that we have with the family after ruling out other problems. So here the close differential will be myasthenia, but the presence of jog jerk being exaggerated, pseudobulbar effect being present, normal kind of ocular muscles involvement, no fluctuation, progressive presentation. These are the ones which makes us tell that this is a bulbar onset ALS. And this is another 17-year-old boy who has come with asymmetric, initially left upper limb and then right upper limb, weakness, wasting, fasciculation, and sometimes worsening of the limb weakness during cold during winter season. And as you can see, there is a finger drop on the left as compared to the right. There is wasting of his forearms, but there is a relative sparing of his brachioradialis. So in a young individual like this, where disease has been there for 5 years, so this is just remained in element kind of presentation. There is no human findings. The reflexes were normal. There was no sensory involvement. There was no sensory dissociation. So the localization here could be to the cervical cord. It could be to the anterior horn cell. It could be to multiple nerves. It is not because of fasciculation, weakness, absence of sensory loss. Sensory nerves are not involved, and because there is weakness, fasciculation, wasting, and neuromuscular junctions and muscle is considered less likely. And so the most likely localization was the cervical cord. It is important in these cases to look for dissociation, because syrinx is an important differentiation in this condition. So this is a gentleman who finally had an imaging done, and on flexion you see the dural detachment that is not present in the neutral position, but on flexion of the neck we see there's a dural detachment. And so this is a monomyelic amyotrophy in the young, the Hirayama disease, what we call. And hence the collar has been given to prevent further flexion-induced injuries. So this is another gentleman who was admitted to the neurology ward with a history of progressive bulbar weakness, as the features of difficulty in speaking, hoarseness of voice, nasal regurgitation, and then subsequently developing progressive hemiparesis on the upper limb and the lower limb over 2 years, and then subsequently developing painless burn injuries over the right hand. Apparently, he had a coffee spilling onto his hand, and he did not realize that he had burnt his hand. And there was also an evaluation that he had significant sleep problems. So the wife was saying he had significant snoring and all that. So in a thin individual. So these were the problems that he had gotten admitted with. We had initially missed the burn injury being painless, and he was being evaluated for juvenile ALS and all that. So subsequently, we detected he had sensory dissociation, and what he had was a syrinx, and this was a Chiari malformation. And that the burn injuries being missed was because he had a sensory dissociation. The pain fibers, the spinothalamic tract was being involved, and that is why he was not able to feel the pain sensation, and the painless burn injuries were an important clue in getting the diagnosis. So young patient presentation like this, cervical cord is an important differential here. This is another gentleman who come to the neuromuscular OPD, 64-year-old man who has come with 4 years history of difficulty in speech, swallowing, occasional nasal regurgitation, but no progression after that. He had also mild difficulty in getting up from squatting position. He has remained relatively plateau for the past 4 years. The gentleman was labeled as motor neuron disease outside, resolved since the past 4 years. So the interesting point here was when we clinically examined him, that there was only element findings that we were able to elicit in him. There was upper limb, lower limb, you clearly see is wasted, there is fasciculations. We could not get any history of any pseudobulbar effect. There was no history of any fluctuation, ocular involvement. And the lower limb weakness was also proximal symmetrical, not the asymmetrical distal weakness that one normally associate with this. So when we did the examination for him, we picked up in the nerve conduction. Sorry, I forgot to keep it, that he had some subclinical sensory nerve involvement also. and his EMG showed predominantly chronic changes. There was no acute denervation changes. And so, considering an old man who's come with progressive element kind of presentation, bulbar involvement, limb weakness, remaining element for a long period of time, and some subclinical sensory involvement, we consider this possibly could be a Kennedy's disease. Subsequent genetic analysis confirmed the same, and he had a spinobuscular bulbar atrophy or Kennedy. And this is finally the last case which I like to present. This was a challenging case for us. It had presented during the COVID pandemic. Was a 41-year-old lady who worked as a housemaid. Initially, was noticed by a daughter that she used to have neck pain and neck drop when she used to mop the floor. She had some difficulty, and that she had to hold her neck with one hand and mop the floor. Subsequently, she was given a collar for the same. And then progressively, she noted she could not do the sweeping on the floor. She could not get up from squatting position. And by 6 months to a year, she required having a bath. Her daughter used to help her with the daily activities. And nearly 2 months before getting admitted under her, she developed difficulty in lying down, progressive breathing difficulty. And then she had gone to GH for these symptoms and acutely worsened there and got intubated there for type 2 respiratory failure. And so she was labeled as GBS there and given steroids, and then was referred here for the management. So when she came to us, she was in septic shock. She was on high inotropic support, and clinical examination was very difficult for us to get. The only thing, and she was on encephalopathy because of multiple causes here. So it was only the history that was most important. So the onset was neck drop. There was no fasciculation that we were able to elicit. Historically, there was no feature suggesting upper motor neuron dysfunction in the form of tightness, cramps, or any of those symptoms that we normally associate with upper motor neuron. We could not get any history of any cognitive decline. So progression over 2 years, remaining element dominant, the proximal weakness of the upper limb and lower limb, and neck drop. So this was the presentation. This was, though the initial EMG that was done, nerve conduction study which was done, the patient was hypoalbuminemic. And so we could not comment much on the motor nerve conduction studies also, because when you have hypoalbuminemia, when you are in sepsis, when you're edematous, all your conduction potentials seem to be reduced, and we can hardly make any meaningful understanding from this. Because of high inotropic support, she had a very bad lung. We could not reduce the sedation and do EMG properly for her. So the initial EMG that was done actually showed a lot of denervation, and which made us even in the bulbar myotomes. And the initial discussion in the unit was that whether we are dealing with an ALS, which has remained LMN, and this was second week into the illness, she is remaining intubated. A poor family, should we consider prolonging this, an ALS being intubated for two weeks, and we are not reaching anywhere. But subsequently, we were able to wean her off the ventilator. She improved, the sepsis started improving, and once she was awake, we were able to do a better EMG testing for her. Muscle biopsy was deferred because her albumin was 1.2. She was in sepsis, coagulopathic. So if a muscle biopsy was done, she would not have been, we would not have been able to. The wound infection and the wound healing would have been delayed. So we waited, and once she woke up and when we were able to do a better EMG, we found that she had more of myopathy kind of potentials. So considering that she had a progressive LMN kind of weakness, proximal more than distal, neck drop, we consider this is more like an inflammatory kind of myositis. Subsequent myositis profile showed that she had an SRP kind of myopathy. And once the sepsis improved, we were able to immunomodulate her. And by the third week, she was able to be weaned off from the ventilator, and we were able to discharge her on a BiPAP. So these were the interesting and difficult cases that we have faced over time. And at the end, I'd like to just end with this, which has been dealing in clinicians and in students. So this was an editorial by Professor Matthew Kiernan from Australia, where they've looked at a lot of patients, residents, especially in general medicine and neurology, who occasionally have fasciculations and get worked up about it. In fact, he briefly talks about a neurology resident that he had called Dr. Laurent, who in his busy OPD started noticing multiple such fasciculations over his arms. And then he became progressively preoccupied because of that, and he started having suicidal thoughts and thought he's going to die. And then subsequently, after much reassurance, the doctor there was able to make him understand that. So there is an entity called as fasciculation anxiety syndrome, and that this is predominantly where they have only fasciculations. It is predominantly worsened by stress, caffeine, or exercise. And the clinical examination is nearly normal, and the deep time reflex are always normal. And electrophysiology, CPK, and all those tests are normal. So he had looked at 23 such patients over 7 years and followed them up for 5 years. Out of 23 patients, only one patient actually developed ALS. Well, the 22 other patients had benign problems and did not have much problem. So this is an important thing that we must be cognizant about. So I'd like to end my presentation today. Thank you for your patient listening.
Thank you, sir. Thank you so much for this presentation. If anyone has any questions, you can ask now. So I have a doubt. Is there any MND that is like secondary to other conditions like paraneoplastic, and is there any difference in the prognosis?
Okay, so this is a common question that we have. So these are very rare presentations. So in fact, there was an editorial on motor neuron disease mimics where they have called it as myths and legends of paraneoplastic motor neuron disease. So we always, again, the presentation, the most important thing is the presentation and the tempo of progression. So first is the localization. So the presentation could be on a background of us. We consider such possibilities when there is a background history of a malignant disease, background history of neoplasm. So that is when we entertain such a possibility. When there's a very rapid progression, which we consider as unusual, or it's remaining only as element dominant syndrome, or any such alternative, like when we evaluate them for such a rapid progression and we find that there is a lot of systemic findings also in them, like weight loss. So those are the clinical clues in which when we consider. But otherwise, in the clinical presentation, there is not much difference. It is generally the systemic features, the progression of the illness, which actually tells us that. And it is very rare. I think in our clinical practice, we hardly encounter it, or only very rarely have encountered it. But the literature says that lymphoma and breast malignancies are the ones which come like the lymphoma can come with both element dominant upper and lower motor neuron, while the breast malignancy associated motor neuron disease are upper motor neuron predominant. That is what the thing, but it is very rare.
And one more thing, a lot of people go back to their mission hospital. So clinically, when they diagnose MND, is it only always supportive, or is there any treatment that is available now, and can they be referred to tertiary care center?
Yeah. So in the sense that, is there any curative treatment for motor neuron disease? And short answer is no. Is there does that mean that there is no treatment for motor neuron disease? That is not the thing. So symptom management and improving the quality of life is a very important component of care for motor neuron disease. Like I mentioned, it depends, the management of it depends on what is the manifestation, what is the phenotype that you're looking at. So like I mentioned, if it's a bulbar onset phenotype presentation, then we are primarily worried about, it's important for them to understand that, because most people would like to know, if you're having an incurable disease, then they like to know that they need to sort out their affairs. We need to give them that time to that you're dealing with a chronic problem disorder, which is, which we may not be able to cure you, but it's important to make them that is very important aspect of the disease. Second thing is the symptom management. So cramps, pain, fatigue, malnutrition, breathlessness. These are things which we can treat. And in fact, we have successfully managed. Dr. Matthew Alexander had a patient with a respiratory onset ALS who had come to ICU with type 2 failure, got intubated, and we were subsequently called to the ICU. Sir had done a diaphragmatic needling and confirmed that he had an ALS. And then we were able to wean her off without tracking her, take her off into the BiPAP and manage her for nearly 1.5 2 years subsequently. So, we were able to take her. She had multiple setbacks in between, multiple infections, COVID, all those we were able to, take her through that. So, it's important that we manage these small problems which actually make a lot of difference to their quality of life. Otherwise, with regards to some improvement in the, retarding the progression, we always offer these patients Riluzole, and which is freely offered from the government, from through the Sun Pharmacy. And then there's this new medicine, which is a free radical scavenger called as Itaveron, which we also give in certain patients if if they are okay. Once we talk to them and they will be okay with it.
Are there any further questions? If there are no further questions, thank you so much, sir, for the lecture. Thank you, everyone.
Thank you.